more likely to get a urinary tract infection. Diabetes, huge predisposing factor for infections. Neurogenic bladder, these people with a bladder that does not function properly, do not empty properly, and they also have poor barriers against ascending infection from the outside. So neurogenic bladder, huge risk for infection. They also tend to have things to help empty their bladder, like a catheter, so a Foley catheter. And then, so pregnancy. Pregnant women are at higher risk for urinary tract infection than non-pregnant women. End-stage renal disease, because they have low amounts of urine output, so they're not flushing out their bladder. Immunosuppression is kind of a duh. And then congenital anomalies, like we talked about. Reflux. Megagureter is an obstructed ureter in a child, a congenitally obstructed ureter. Okay? So how do we collect urine? This is important. Right? This is one you need to remember. In men, because the pee hole is outside of the anatomy, you can just use a clean catch. You can give a man a cup and say pee in this, and they're going to get a clean catch 9 times out of 10, except in what case? If they have a foreskin. All right, so men with a foreskin need to be told to pull their foreskin back. All right. Otherwise, they're going to just pee into their foreskin and it's going to dribble out. That's going to be gross and infected. Women have to spread their labia to get a clean catch. And honestly, you should tell them this. They don't necessarily all know this. If a woman, particularly a woman who has a BMI over about 35 or 40, is not going to be able to get a clean catch, okay? They're going to need catheterization most of the time if you want a non-contaminated specimen. Now the gold standard is suprapubic aspiration, believe it or not. Why? You can put betadine, or you can put alcohol on the belly, and you can stick a needle right into the bladder, perfectly sterile. Okay, and then you're not going to get any contamination. Now the worst thing you can do, and this again happens to kids. I'm not a pediatric urologist, but for some reason, the interesting things to talk about happen in kids that aren't cancer. Who gives your cancer talk, by the way? Kidney, bladder.
Well. One of the PAs covered the prostate cancer, and did she cover bladder? Yeah, bladder cancer.
Okay.
And then I've got another urology PA coming to talk about renal cell.
Okay. Who's that?
I can't think of her name.
My real job is I work at the cancer center. I'm really a
Pde5. Do you know Pde5?
No, I don't. I'm sure she's awesome. So anyway, as I was saying, for collection, all right, one thing that people do for a kid, they're like, oh, the kid has a urinary tract infection, but hey, we can't get the kid to pee, so we'll just put this bag over their genitals until pee comes out. And that's a real thing. They have a little bag you glue onto their, over their perineum and wait for pee to come out. And it's horribly contaminated. Okay, you don't get a clean specimen. And so, so one of my pediatric urologists at OU makes the point to his pediatricians who do this bag specimen. He said, and he's German. He says, "What? If you want blood, are you going to punch them in the nose and pull the bag under it? It's gross." So the moral of the story is, don't get bagged specimens for pee. If you want to know why your kid with 103 fever in the ER has a fever, you put a catheter in them. You think, oh, that's horrible. Why would I do this? Well, you put needles in them and get blood anyway. Sorry, I'm on call, and we're good. Putting a needle in them to get blood, just put the catheter in and get some urine. Okay, so urinalysis. I belabored that point. But urinalysis. So let's see what we have. So the things that we look for in urinalysis, you dip the stick in some pee, and then it's like checking the chlorine in your pool. It turns different colors. And this can all be read by a machine, or you can compare it to a little chart on the back. And so for infection, the big things we're looking at are the top two here, leukocytes. All right, so presence of leukocytes in the urine. Can the dipstick tell you if there's a white blood cell in there? No. it can only tell you if there's the breakdown products of white blood cells. So it's looking for leukocyte esterase. And so nitrites are another one. What causes nitrites? Well, if the bacteria metabolizes ammonia, it will split nitrate into nitrite, and that will show up. And it's about the only thing. So if you have positive nitrite, you probably have a urinary tract infection. Negative nitrite means nothing. Why? Because there are bacteria that do not make nitrites. And then really nothing else on here is going to help you for the purposes of infection. So you can ignore the rest if you care about only about infection. All right, so we talked about sample collection pitfalls. As far as the urine dipstick, the chemical tests are based on color. And so if the urine is off color, then your dipstick is going to be wrong. And so people will sometimes have blood in their urine, can't tell much from a bloody specimen by the dipstick. They might also be taking a medication called Pyridium. Does anybody know what that does? Yeah, it turns their urine bright orange. And so that will screw up your urinalysis. And so if you have some doubts about what you're getting, do a microscopic exam, just send it down to the lab. And the gold standard then is culture. All right, so talking about lower urinary tract infections, what we're talking about is cystitis, urethritis, epididymitis, orchitis, and prostatitis. The vast preponderance of what people call, oh, I have a UTI, is a simple cystitis, okay? Stinging and burning with urination, maybe some suprapubic pain, and frequency, and urgency. That's a standard cystitis. Urethritis happens in men. Women don't have much of a urethra to speak of, but men, urethritis is caused by what? Anybody? Gonorrhea and chlamydia, STDs. Epididymitis and orchitis, same for young men. Older men tend to have it caused by E. coli. And prostatitis, if it's acute prostatitis, also usually E. coli. So acute bacterial cystitis is predominantly in women. Almost 80% is E. coli, and the symptoms, like I told you. Your urinalysis will typically show a positive leukocyte esterase, probably a positive nitrite, but not always. But the urine culture is the definitive test. So if you have somebody that you get a UA and it looks like they have a urinary tract infection, you don't have to wait for the culture, especially if they're symptomatic. The gold standard now is a 3-day course of trimethoprim sulfamethoxazole. Okay. Why that drug and why 3 days? Because 3 days works as well as anything else. And we don't like to use fluoroquinolones for uncomplicated urinary tract infections. Okay? Fluoroquinolones are in fact now black box warning for use in simple urinary tract infections. An alternative, especially for patients allergic to Bactrim, is Macrobid. I put on here 100 milligrams POBID times 3 days. That's not correct. It should be 7 days. Macrobid does not kill the bacteria as well or as quickly as Bactrim does, and so you have to use at least 7 days. Fluoroquinolones should be reserved for complicated urinary tract infections. Those are immunocompromised diabetic people or people who came straight from the nursing home to the hospital. Those are never simple infections. Okay, so people who get another infection, you have to determine if this is reinfection. So if they are getting new infections, continually getting new infections over and over again, or if they're not able to clear the infection. Okay, so if it's just back to back, they never became asymptomatic, it's probably persistent infection. And then you image them, get an ultrasound, IVP, or kind of going out the window, or really what you're usually going to get is a CT scan. CT scan will show, honestly, most of the time these patients stones, sometimes an obstructing stone. You fix that, infections go away. All right, so patients get reinfected over and over and over again. One thing you can do in women who are postmenopausal, you can put them on esterase cream in their vagina. If that doesn't work, a lot of these people, we just put on low-dose prophylactic antibiotics. And it's a big quality life improvement. Does it help with their long-term survival, prevention of the one that kills them? Probably not. But they don't get back-to-back infections anymore. Other types of cystitis. Uh-oh, they're really trying to get hold of me. Not am on call. Let me just send him a text to say to text me and tell me what's going on, and then I can determine if I need to interrupt the lecture. Bad timing. I just had me on call today. So pyocystis or pyelocystitis occurs in patients that don't really have a lot of urine output or their bladder's blocked. This occurs in patients who we divert the urine away from their bladder for long periods of time, and then they get an infection that just, their bladder becomes like a huge abscess. Okay? You just have to drain it and then give antibiotics and get better. Empysematous cystitis is where the bladder starts to get full of gas, and in fact the wall of the bladder can get full of gas, and then it can actually pop, and that's no good. Now, interstitial cystitis you'll hear talked about, and this is not an infection. Okay, interstitial cystitis is a problem, again, primarily in women, that is associated with pain, primarily pain. And it's debilitating, but it's not associated with infection. So I won't say a lot about interstitial cystitis except that you don't want it. It can be treated, but it's very difficult to treat. Probably should be managed by a urologist. Prostatitis. So there are two major categories of prostatitis. One is acute. So those are like severe, like chills, fever, low back pain, perineal pain. If you touch their prostate, they don't like it. Of course, no one really likes it, but they really hate it. It hurts badly. And that's a long-term course of antibiotics. And if that fails, like if they're still having symptoms after 3 or 4 days, you've got to image them because they may have an abscess, which needs drainage. So chronic bacterial prostatitis is a long-term problem. And in fact, a lot of these end up, you do treat them with antibiotics, they do get better. A lot of them come back after a couple of months, and it's almost impossible to get rid of. There is a third entity which is probably confused a lot with chronic bacterial prostatitis, and most of what people call chronic bacterial prostatitis is probably this, chronic pelvic pain syndrome in men. Okay? So they don't have a positive culture, they don't have white cells in their urine, but it does respond to antibiotics. Okay? They have pain with ejaculation, low back pain, testicle pain, symptoms of bladder obstruction or even infection. And you treat them with alpha blocker, like Flomax is the one I use, NSAIDs like Aleve or Advil, and a fluoroquinolone antibiotic. And 80 to 90% of them get better with that, but you take them off of everything and they get worse again. So it's chronic and it's horrible, and I will tell you that it seems like most men eventually grow out of it, because I don't see 70-year-olds with this, so either it kills them or they grow out of it, I don't know which. Epididymitis orchitis, so infection of the testicle, often this is what you're going to see when you rule out torsion, not torsion, probably is epididymitis or orchitis. So trying to differentiate between one of the two is a fool's errand. Most intrascrotal infections are infections of the epididymis. Okay, it's on the back side of the testicle. You may squeeze the testicle itself, and they go, oh, no, that's fine. And you squeeze the back where the epididymis is, and they go, ooh, that really hurts. Okay. The only thing that really causes epididymitis or really causes orchitis without epididymitis is mumps. Really not a cure, it's just got to run its course. But so you treat epididymitis with antibiotics, usually gets better. You treat younger men as if they have STD, you treat older men as if they have E. coli. So. Urethritis in women is really probably vaginitis most of the time. The big causes are Candida, which looks like that. So you do this wet prep, and then you see these under the microscope. Most of the time you're not doing these, I don't know, does anybody here work with a gynecologist? I don't know any gynecologists that do wet preps in the office anymore, but they do.
I think Lisa, Dr. Lisa Weissner, Lakeside, she still does wet preps, I think.
Does she?
Mm-hmm.
I mean, good for her. I mean, I really think you should be able to do them in the office. Like I have a microscope in my office, and I don't even know if it turns on. So this is what you see with Trichomonas. This is a strawberry cervix, and that's fairly uncommon. The thing about Trichomonas is it's asymptomatic in men. All right, so if you have a woman who you find has Trichomonas, you should treat their male partner, else they'll get reinfected again and again and again. Bacterial vaginosis, you have what's called clue cells, and I guess that's what it looks like. Again, I don't typically look at these. These are epithelial cells here that are covered with bacteria. Okay, so you treat it with metronidazole flagyl. So upper urinary tract infections include pyelonephritis, is the general standard run-of-the-mill. Pyelonephrosis, which is basically an infected kidney that's blocked. Renal abscess and xanthogranulonous pyelonephritis. We have a slide on that, we'll see. So pyelonephritis is the triad of chills, fever, and flank pain. And you do not typically see, imaging diagnosis, meaning you can't get a CT scan or ultrasound and go, oh, this is pyelonephritis. If somebody has chills, fever, flank pain, and a urine consistent with urinary tract infection, they have pyelonephritis. There's really no other way to define it. It's very often, the presenting state is pregnancy. Pregnant women tend to get pyelonephritis. Why? Because the drainage of the kidney gets disrupted by the size of the uterus, and then you tend to get urinary tract infections. They get, urinary tract infection that becomes a kidney infection. It's bad because it's a significant risk factor for preterm labor. So this is the only case, women who are pregnant are the only case where you get a urine culture and you treat them even if they're asymptomatic. Other patients who you get a culture and you find out, okay, oh, they got E. coli in their urine. Does it sting when you pee? No, it doesn't sting when I pee. Don't treat them. But if they're pregnant, you treat them. Okay? So treat them. So all people, the general first liners, ceftriaxone and gentamicin, and if they get better quickly in the hospital, you send them on oral antibiotics for 2 weeks. Okay, so an abscess of the kidney generally arises from pyelonephritis that goes untreated for some time. The real problem with an abscess of the kidney, and this is where the abscess is down here. The real problem with the abscess of the kidney is that generally antibiotics don't work for them once they get to a certain size. That size, if you're ever asked, is 3 centimeters. Anything less than 3 centimeters is going to get better by itself. But an abscess 3 centimeters or greater needs to be drained. Okay, so that's why if somebody has pyelo and they're not getting better, you need to get imaging on them to make sure they don't have a renal abscess. This is the extreme state of kidney infection, xanthogranulonous pyelonephritis. We just say XGP. So now if I say XGP, you know what I'm talking about. It's a kidney that looks very calcified or, for lack of a better term, funny on a CT. If I see it, I know what it is immediately, but some radiologists who haven't seen it will call it a tumor or an infection. It basically means that they have a persistently infected kidney, and the only way to get rid of it is to take the kidney out. Okay? Antibiotics don't work to get rid of xanthogranulonous pyelonephritis. This is a chronic condition. People don't come into the ER with it unless they're getting super infection on top of it. Okay, that's infections. Questions about infections of the bladder kidney? I know, quick and dirty. All right, and now everybody's favorite topic, erectile dysfunction. Okay. We're going to talk about the anatomy, we're going to talk about what causes erectile dysfunction, treatments, and this is adapted from a resident lecture. SASP is questions. I don't have any questions, sorry. So this is the cross-section of a penis, a theoretical disembodied quarter-inch of a penis. But so what you see is that you have this thick outer layer called the buccal fascia, and then on the next side you have another even deeper thick layer, and that's called the Tunica Albuginea of the corpora. And these invest the corpora and make it tight. They're non-expanding. Most of the fascia layers in your body are flexible and will expand. This does not expand. So what happens is the blood comes in through these emissary vessels, okay, and it fills these sinusoidal spaces and expands, and out here you get squeezing of the veins that drain the penis, and now nothing will drain out. Okay, so the act of it engorging causes the drainage to be poor, and so it takes very little continued blood flow to continue an erection. Okay? Blah, blah, blah. This is, you don't need to know. Suspensory ligament is not going to come into play. There is a ligament that goes from the pubic bone for the penis. That's why it's an erection and not pointed at the floor. So you need to know that you have sympathetic and parasympathetic innervation to the penis. The parasympathetic innervation is what causes the erection, and sympathetic innervation was what allows ejaculation. You remember that by point and shoot. Okay? Point and shoot. Parasympathetic, sympathetic. So why do we have problems with erectile dysfunction? And actually, it can be more complex than you might think, because erectile function is critical for reproduction. So those processes which are critical for reproduction tend to be very well protected in us. So reasons that you would have erectile dysfunction come down to really pretty serious systemic diseases. The biggest is arterial insufficiency, caused by coronary artery disease and peripheral artery disease. So of men who present in their 50s with erectile dysfunction, like over half of them have coronary artery disease already. That's something to think about in primary practice. If you're going to practice in primary care, you see a guy complaining of erectile dysfunction in his 50s, you go, oh, you might have actually some pretty severe problems going on. Okay, so besides the most common, which is arterial insufficiency, they can have, neurologic causes at any of these levels. Hormonal is kind of the go-to. A lot of people go, oh, well, okay, it means your testosterone is low. And absolutely, you should check a man's testosterone if he has erectile dysfunction. But it's really not the most common cause. And often correcting the testosterone doesn't always provide, in fact, very seldom goes back to, okay, now my erections are perfectly normal. Or you can have problems with the penis itself. The most common is venous leak syndrome, where a guy will get an erection, but then he can only keep it for about 30 seconds to a minute, and that's what causes erectile dysfunction most in young men. Okay, and that's where the veins are not constricting off the blood coming out of the penis. I just remembered, I told that guy to text me and I didn't look. So these are some of the diseases that people can get that will cause erectile dysfunction. Hypertension, diabetes is the worst, all right? If you're a diabetic man and you get erectile dysfunction, first off, it means your diabetes has gone to the point where it's probably affecting, it's a form of peripheral neuropathy you can have associated with diabetes. It also affects the small vessels going out of the penis. So diabetes is a small vessel disease. And so these men with diabetes and erectile dysfunction, pills don't work on them. Okay, you'll try them, but they don't work. Diabetes causes horrible erectile dysfunction. Okay, liver failure, alcoholism. So in fact, substance abuse in general, marijuana, alcoholism, and opiate use all cause erectile dysfunction and are often forgotten. And I said, can I call you in 30 minutes? And he says, yay, that's fine. All right, so you get to hear me talk. So some people, now there's this theory, and I'm not sure if I agree with it or not, but it could at some point be something you encounter in practice or on a test. Beta blockers and thiazides are associated with erectile dysfunction. Okay? it's kind of hard to separate the disease from the medication used to treat the disease. All right, so is the beta blocker actually causing the erectile dysfunction? Maybe. Am I, as a urologist, going to tell a patient with CHF to stop his life-saving treatment? No, I'm not. And so I don't tend to, maybe it's true, but I don't tend to put a lot of stock in it to patients or anyone, because you're not going to change it. You're not going to take them off their beta blocker if you've got them on, especially for CHF. Thiazide diuretics associated with erectile dysfunction. Again, probably not changing. Now, if it's possible to treat patients with erectile or with hypertension with an ACE inhibitor, calcium channel blocker, angiotensin II receptor agonist, or ARB, those are better choices than beta blockers and ACTZ. It just so happens that beta blockers and ACTZ are very specifically very, very good for hypertension with CHF. Antidepressants, all right, #1 cause, medical cause, all right. SSRIs, horrible erectile dysfunction. Do you guys remember the Effexor commercial where the guy said, and the lower cause of sexual side effects, and he seemed very happy about it. It's like burned in my brain, but it's true. It's true. SSRIs are really bad for sexual dysfunction in men. Not only does it cause erectile dysfunction, I've had guys come to my office where they physically can't feel their penis. They have an anesthesia to their penis from their SSRI. And all SSRIs do it. You can't put them on a different one. You just say, hey, what do you want? Do you want to be not depressed or feel your penis? And that's real. But that's a real thing. It's documented. Digoxin, thankfully we don't use a whole lot of digoxin anymore, but it causes drop in the testosterone. They get hypogonadism and erectile dysfunction. A couple others that are supposedly cause cimetidine is no longer used anymore. It's a H2 blocker. Spironolactone is a potassium-sparing diuretic. Anticholinergics, which I do use quite a bit for anything with anticholinergic side effects, though, in general, can cause erectile dysfunction. So high doses of Benadryl, like you got your guy taking 50 milligrams of Benadryl 2 hours before he goes to bed and then he can't perform. Can't do that anymore. Smoking, big cause. Smokers get bad ED because it causes vasoconstriction of those vessels and poor flow into the penis. Alcohol, like I said, helps in moderation. Everybody knows that. But large amounts cause sedation, and it can cause, over time, liver disease. And alcoholics get polyneuropathy, which causes erectile dysfunction. Okay, so like I said, the most common is arterial, and there's a pretty high prevalence of erectile dysfunction in patients with coronary artery disease. And the good thing, like I said, ED precedes CAD symptoms, all right? So if they've got erectile dysfunction and they're young, and they're like, oh yeah, I'm healthy. Do you have chest pain? No, no chest pain. That's a patient you might want to get a stress echo on or something. Because before you start giving them, pumping in Viagra, well, I haven't had intercourse in 2 years because I've had erectile dysfunction. I'm finally getting something done about it. Well, do you ever get short of breath going up and downstairs? I don't know, I don't do much. I don't get off my butt much. Those are the people you got to be worried about, because you give them Viagra and they start pumping blood when they're, now having intercourse, and they can die. People do have heart attacks. This is why Viagra has been blamed in a lot of cardiac events, probably because it's increasing their metabolic rate in patients that really have no other metabolic stressors. So, just put that in your pipe and smoke it. So statins actually have been shown to improve erectile function in people with CAD. People at, this is from an article I looked up. The mechanism. I forget about the mechanism. But just remember, statins can improve erectile function over time. The big treatment is Pde5 inhibitors, all right? Sildenafil, vardenafil, tadalafil. Sildenafil is the big one, that's Viagra, just went generic, okay? You can now get Viagra at Flourish Pharmacy, 50 pills for $50, all right? Don't leave yet. I tell my patients this and they get really stoked. So the general cascade is you get nitric oxide released from the nerves, which stimulates guanylate cyclic GMP, is then broken down into, cyclic G is then cyclized from GTP to cyclic GMP, which causes increase in calcium going to the endoplasmic reticulum, and then you get contraction of smooth muscle. All right. The breakdown product of that is 5' GMP, and it's broken down by Pde5. So your Pde5 inhibitor prevents the cyclic GMP from being broken down, which results in, again, more calcium. I'm telling you wrong. Decreased calcium, which causes smooth muscle relaxation. That didn't make sense to me when I said it either. Smooth muscle relaxation. That allows your blood vessels to expand. It allows the blood to flow into the penis, and then you get an erection. So that's why Pde5 inhibitors work. Okay? They are not very effective in diabetes because the vessels are crunchy and the vessels do not relax appropriately. They're not very effective after prostatectomy because patients after prostatectomy have had nerve and vascular damage, and so the blood doesn't really have a pathway into the penis. They are very efficacious in patients who have depression. Why? Because it's kind of like a placebo effect, plus it actually works. So these patients have a lot of effect from even low doses. So Pde5 inhibitors, the number one cause of not working or not staying on it is that number one, they just don't want to use it. Okay, so you give a patient his Pde5 inhibitor, will come back 6 months later. I can't tell you how many people say, yeah, I didn't really use it. Like, okay, well, why not? Oh, well, I didn't feel like it, right? So a lot of people get it and they just don't use it, or they don't have a partner. Cost is a big deal, all right? They used to be $16 a pill, but only 12% of people who discontinued it said cost was a factor. Weird, okay? And then side effects. What kind of side effects? Changes in vision, headaches, sinus stuffiness, muscle cramping. When you give somebody a Pde5 inhibitor pill, you want to talk to them about it. It is very tempting to say, ooh, erections, gross. And give them a pill and say, just take the pill, you'll be fine. You have to tell them how to use it, all right? Number one thing you need to know is you have to have stimulation. They don't take the pill and just get an erection. They have to have stimulation. So people don't understand this. And so you have to tell them you use this during times of stimulation. The proper timing. So Viagra, an hour before, an hour to 2 hours before. It lasts for 6 to 8 hours. So if they take it and then jump in the sack, not going to work. They got to take it a couple hours before. Cialis, tadalafil, even longer, 4 to 8 hours, and it lasts for 24 hours. Okay, dose titration, we tend to start low and go up. You can use, I think I have a slide, you can use up to 100 milligrams of sildenafil and still be within FDA guidelines. It's safe up to 200 milligrams, but they get more side effects. Okay? And then talking to the partner is always helpful. The partner hearing that erectile dysfunction is real, that it's not anybody's fault, and they need to be patient is important. So in one study, there were 41% of people who were like, this stuff doesn't work. They got education, 41% of them suddenly it was working. 55% in another study. So education is important. Unfortunately, patients over a long term have less success when they're counseled by a primary care doctor. Again, in primary care, people are not as knowledgeable or experienced, don't do it as often, and are not as willing to spend the time discussing use of a erectile function medication. So sometimes also primary care doctors are the reason they're not getting treatment, because they're not asking about quality of life issues like sexual function. Okay? The reason I put this on a slide and talk about it is there is a hundreds of thousands to $1 million industry in Oklahoma City of people coming on the ad. Greg from your Oklahoma Men's Clinic does not exist without primary care doctors keeping their mouth shut about erectile function. Okay? So the guys just think no one cares, and so they're listening to the sports animal. Someone comes on and says, hey, I care, I'm going to get your erections back. They go to them in droves, so they make a lot of money. And I don't know if I have a slide on here about this place. I'm probably not going to wax poetic about that anymore. The more people try, the more likely they are to have success using a Pde5 inhibitor. And like I said, if you don't respond within normal doses, about 24% of people who had no response, you go up to super doses of Viagra. It works, but then they stop using it because of side effects. There's no good evidence that switching from one Pde5 inhibitor is going to help if you go to another one. They're all essentially the same. So, well, Viagra didn't work for me, let's try Cialis. Really just waste time and money. A lot of those people need to move on to second-line therapies, which we'll talk about in just a second. So testosterone replacement. Okay, you check their testosterone. If their testosterone is normal, do not pass go, do not collect $100. Not going to help them replace their testosterone if they're in normal ranges already. It does, in some ways, modulate the nitric oxide cyclic GMP pathway, so it can improve the efficacy of Pde5 inhibitors if they have low testosterone and you bring it up to normal. So they have to have normal levels, but going past that is not going to help anybody. That's basically what I just said. Okay, so ICI, intracavernosal injection. The old tried and true is alprostadil. Whoa, where are we putting it? Into the penis. That's right. Injections into the penis. All right. So cyclic it increases cyclic AMP, which is on the other end of the cascade, but it does result in decrease of calcium. And the only problem with this is they get a side effect of pain and burning at the injection site in about a third of men. There is a risk of priapism. All right, priapism sucks. That's where their penis gets hard and it won't go away, and it's still there for 4 hours, and then it becomes pathologic. Okay, it becomes self-sustaining, and so you have to inject phenylephrine. You have to aspirate blood from the penis. It's no good. You don't want priapism. It usually causes from poor dose titration. Yes, ma'am.
Doesn't they increase the risk for infection?
You know, I've never seen a penile infection from intracavernosal injection, and I've never heard of one.
Okay.
Sure it's happened. I'm sure it's happened. But, you know, if you're injecting something in an area of that much blood flow, probably not going to get infected. The immune system's going to deal with that small amount of bacteria introduced pretty readily.
Okay.
And, you know, people who are sick and immune compromised, they're not using these anyway. Once you get guys up and running on this, they actually like it. It works pretty well. So another agent used is papaverin. It's lower incidence of penile pain, but a little higher incidence of priapism. It inhibits phosphodiesterases locally. Phentolamine inhibits alpha-adrenergic receptors, so it relaxes the blood vessels directly. It inhibits detumescence, but it doesn't induce an erection. So why do I mention these two? Because we can use them all together. It's called trimix. The best thing that you can do. I'm talking here about the addition of ICI to Pde5 inhibitors. Honestly, I don't have people use Pde5 inhibitors when they're using intracavernosal injection. I figure it's enough punishment to be putting a needle into your penis. But so, of the men that these work for, it works best in men with neurogenic disease. It works very poorly in men with veno-occlusive disease. If they are able to obtain rigid erections with intracavernosal injection, then they probably do not have Wait, did I just, I actually deleted that slide. That's unbelievable.
Control Z, you can get rid of it.
Right. Right. And I've been doing this, oh my gosh. So today we're gonna talk about, I never put it back in slideshow mode, so you guys will be getting the small version. So I'm gonna give you the large version of this. So this is the nuclear weapon of,
Up in the top, over that.
there we go. This is the nuclear weapon of erectile dysfunction, and then we do this. I'm doing one in a couple weeks. Yes, you implant these puppies directly into the penis. You put this balloon up in their belly, and this pump shifts fluid from the reservoir into the prosthesis, and erection occurs. The head of the penis, the glands, does not become hard, but this works great. Partner satisfaction is actually higher than the patient satisfaction. Only problem with these is that they break over time. They have to be replaced, or by that time they're usually too old to know anything. And that is it. So questions about erectile function, anything we talked about?
So how do they test in the abdomen to get the pump?
Nope. There is a little pump that goes down in the scrotum. It's like a third testicle down there. And you just, yeah. It's like the relock pump for the penis. It does not replace the testicle. You embed it in the skin on the anterior scrotum. There's another button on the pump.
Okay, so this whole thing, and my grandpa had it done.
Whoa, how do you even know that?
Because they told my mom, and my mom was like, Grandpa's going in for surgery to get his penis replacement. And I was like, oh, that's gross.
Yeah, well, that's the thing. The last one of these, I've done this on an 87-year-old guy. Okay, and there is a direct relationship between the age of the guy and the size of his penis when he gets this done. Because if you're gonna if this 87-year-old guy, it was ridiculous. But he had to have the prosthesis. I was like, you're 87. I mean, really? He's like, oh yes.
Good for him.
They're having the ICI treatment. How often do they have to have that done?
It's just episodic. They get an erection within 5 minutes.
Okay, so they have to inject versus taking a pill each time?
Yeah. They have to inject each time they want an erection. It's great. They love it. All right. Thank you, everybody. Good luck. If you have any questions